The title of this presentation is Every Port Needs a Cap, and we do believe that every access point in an infusion system needs protection from pathogens. My name is Jill Nolte, and I disclose employment as a clinical resource manager for Medline Industries. Becky Piccioni helped author this presentation. These are the objectives for this presentation: to explain function and efficacy of disinfection caps, examine current guidelines and recommendations for disinfection caps, and to outline methods to support disinfection cap usage in your facility. There are about 40 content slots. Before we had needleless connectors, we had needle injection ports. If you used one of these, you've probably been around a while. The process was to use an alcohol wipe to clean the surface, then insert a sterile needle to deliver the infusion. It was a good system with a clean port and a sterile needle, but there were lots of sharps involved, and accidental disconnections were a problem. The search was on for a way to eliminate accidental disconnections. As healthcare looked for ways to reduce needle sticks, we moved away from these injection port systems and onto split septum systems. Split septum systems and blunt systems reduced needle stick injuries, but they were not always favorites with caregivers. These devices did not eliminate needles, as they were still used for needle injection ports at times. The parts themselves are clunky, with lots of surfaces and lots of pieces. Split septum systems were cumbersome to use. All those parts meant a lot of inventory to stock and to store. There were compatibility issues across the continuum of care, especially problematic with rescue meds and code carts. These devices were intended to be accessed in the center of the port, though in practice were often accessed around the outer edges of the port. Nurses complained of leaking, and some types were really hard to flush clean. Add to that, a single device could only be accessed a limited number of times, with no way to track that information. So onward we went to the next innovation: needleless connectors. Attempts to reduce the incidence of sharps injuries and the resultant risk for transmission of bloodborne infections to caregivers have led to the introduction and mandating of needleless infusion systems. Needleless connectors have shown to be effective in decreasing sharp injuries to healthcare workers, but they've also been associated with increased risk of catheter-related bloodstream infection. Needleless connectors are available with negative, neutral, and positive displacement. The flushing clamping sequence with each type varies. If more than one type of connector is in the facility, there will be complications such as clotted lines, which can lead to infections. When product changes, appropriate training should be provided. Manufacturers have studies with their respective needleless connectors, and instructions for use are provided with the connector, but these IFUs are not always available to bedside caregivers. The IFU is typically found on the box or on a pamphlet in the box, which is thrown away in central supply. On this slide are some quotes from IFUs for various connectors currently or previously available on the market. IFUs are typically based on studies. Manufacturers know what is needed to clean their device, and it does vary. Failure to adequately clean leads to infection. I do not know what the manufacturer's IFU was or is for this device. This is the first needleless connector I personally encountered. My instructor was an ICU educator, and this is exactly how I was taught to clean the connector prior to attaching infusion tubing or a syringe. Probably some of you can relate. The needleless connector has been referred to as the microbial gatekeeper for vascular catheters. Studies have shown that how it is decontaminated directly impacts how many organisms enter and how quickly biofilm will form. Biofilm and all those bugs that lead to bloodstream infections. Bloodstream infections are exactly that, infection in the bloodstream, not infection in a specific device. We don't have a classification known as PIC-associated bloodstream infection, or IJ-related bloodstream infection, or even a PIV-related bloodstream infection. Bacteria make no distinction in the type of catheter they enter. Infection comes from intraluminal and extraluminal sources. Even the very best securement, the very best dressing, and meticulous site care will not address intraluminal infections. Intraluminal colonization becomes a significant risk factor for CLABSI with increasing time of placement. Failure to disinfect hubs and caps can lead to the development of intraluminal biofilm, which may lead to infection. Microbial biofilms on the intraluminal surface originate from microorganisms transported through contaminated injection ports, needleless connectors, stopcocks, and catheter hubs. Intraluminal infections are a source of catheter-associated bloodstream infections. Catheter-associated bloodstream infections are referred to using various terminology. These terms have different meanings, but we use them interchangeably, which can be confusing. CABZ is associated with all catheters: PIVs, midlines, PICCs, CVCs, art lines, pulmonary artery catheters, catheters that are medicated, non-medicated, tunneled, non-tunneled, cuffed, non-cuffed, all of the catheters. Catheter-related bloodstream infection is a clinical definition. Lab testing is required to identify the catheter as the source of the bloodstream infection. CLABSI means the patient had a central line within the 48-hour period before developing a bloodstream infection, and it is known that the bloodstream infection is not from another site. CLABSI is used for surveillance and must be reported to CDC's National Healthcare Safety Network, NHSN. In our quest to eliminate all bloodstream infections, no matter what we call them, we started with a focus on insertion bundles and got the word out that these infections were a tremendous burden that deserved our attention. Most of us know by now the impact of CLABSI on our patients, hospitals, and finances. Now that insertion bundles are more established, we find the need to shift focus of CLABSI prevention from insertion to care and maintenance. Unprotected access points, such as needleless connectors, are in unknown and sometimes dubious environments. Patient beds with food, soiled linens, contaminants from skin, as well as airborne pathogens, some things we see and some we don't, can exist on the access point. The access point then becomes a portal for patient bloodstream infections unless it is thoroughly scrubbed. Do you know how to bathe a baby hedgehog? What soap will you use? How hard can it be scrubbed? And how will you get into all the nooks and crannies? We probably won't all do it the same way. In the same manner, scrubbing surfaces and threads of needleless connectors is performed inconsistently with various amounts of friction and time. We find irregularities in surfaces on needleless connectors. Add to this the variations in disinfectant solutions with different dry times can lead to variable results in microbial kill. Guidelines for disinfecting technique are not well established at this time. An easy way to standardize practice is to incorporate the use of disinfectant caps. Called port protector, alcohol caps, barrier caps, antiseptic barrier caps, disinfectant caps, end caps, these devices are intended to be used on lower access valves to be a disinfecting cleaner prior to line access. These caps also act as a physical barrier to contamination between line accesses for patients at home or in a healthcare facility. There are other disinfection options available in the market. This discussion is specific to disinfectant barrier caps.
Awesome, and it's time for our first poll.
I can't wait. So as Blake pulls it up, our facility uses disinfection caps on every port, central lines only, specific populations like ONC, or no lines, we don't have them. You guys know us so well now. You're on it so quickly.
I'm
Jill,
starting
I
to-
love the cap.
yeah, Jill's master of animation here. I love it.
Thanks. I'm anxious to see the results.
Me too. Okay, we're at 61%. Blake,
So 50% said every port every time.
wow.
Wow.
27% said central lines only. And then 14% said we don't have these.
What do you think, Jill?
Well, congratulations to every port every time. Wow, that's good. That's very good. The ones that said central lines only, who made that decision and what did they base that decision on? How did they decide which lines they were going to protect and which ones they weren't? If we choose specific populations, like just our oncology patients, what happens when that oncology patient shows up on a med-surg floor? And then the patient saying, why don't you have those caps? Or what happens when you have a nurse that floats from one floor to another floor and her practice has to change? She has variability in practice, and variability leads to poorer outcomes. In addition to how much friction to use and how long to scrub, every nurse's perception of time varies. We see this a lot when we go and do audits on CHG scrubs, and they don't really have a good, consistent grasp of what 30 seconds is like. Or, to get people to wash their hands for a long enough period of time, we have them sing happy birthday, right? So I have to apologize in advance, but I have a song to suggest for giving us kind of a guideline for an adequate scrub time. You want to hit it, Blake?
Baby shark do 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 do, baby shark do 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 do, baby shark. Baby shark do 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 do, baby shark do 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 do, baby shark do 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 do, baby shark.
Oh,
You guys
excellent.
can't leave the webinar just because we played Baby Shark.
Yeah, no, but that's 15 seconds. And I'm very sorry that I did that to you. You could sing Baby Shark twice, or maybe you could just get some disinfection caps. Your choice. So next slide. Applied to a swabbable lure access valve, such as a needleless connector, the cap provides a physical barrier to contamination from contact or airborne sources between line accesses. Disinfectant caps also provide a disinfectant cleaner for needleless connectors. These caps disinfect, then function primarily as a barrier until the cap is removed. One product is able to provide continuous disinfection by bathing the connector in 70% isopropyl alcohol. When exposed to 70% isopropyl alcohol, harmful bacteria absorb the solution, causing the cells to swell. Then the cell wall breaks down, spilling the contents, and the microbe dies. An in vitro study found that after 30 seconds of contact time with the cap, there were 0 colony-forming units found on the IV connectors. Disinfection caps have proven effective in microbial kill of these organisms commonly found on the patient and in the environment. Staph, E. coli, Pseudomonas, and Candida are all subject to microbial kill using disinfection caps. The reported time to microbial kill varies between available caps. Some indicate 30-second disinfection time. Others report a full minute is needed for reliable disinfection. It's important to understand how the cap you are using works. As for how long the antimicrobial action is sustained, one cap offers 7 days continuous disinfection plus physical barrier protection. Others provide an initial disinfection and then offer only a physical barrier protection for 7 days if the cap is left in place. If the cap is left in place, it will offer barrier protection for the lure access valve for 7 days. That is to say, if left in place, as I have encountered clinicians who understood one cap could be used over and over for 7 days. As the cap is unlikely to be labeled, it wouldn't be clear when it was placed, and we must consider these single use to be thrown away when removed. For the next poll question, keep in mind this is anonymous. Most of us have misunderstood or received incorrect instructions at some point, and cutting corners is not uncommon in healthcare.
Which leads us to our very next poll. And here you go.
Never reused a disinfection cap.
I love the honesty. I appreciate that.
I do too, so
right?
much.
When is that hat gonna go, Blake?
Oh yeah, good call. Here, let me click. No worry, guys. No more baby shark.
Yeah, they're afraid to. That's it. They're afraid to say.
So we, it's kind of a split, but it's, 73% said telling the truth, never reused a disinfection cap. And then the other 27% was like, shh.
Kind of did.
I said, I appreciate the honesty.
Yeah.
As long as Shelley DeVries isn't watching, yeah.
She might be.
No doubt. Very good.
Yeah, so good job. It could be that they didn't understand the disinfection cap, how it was intended to be used, were never educated on it correctly, or maybe the caps weren't available. So think about why a cap was not available. Did the nurse before you use the last one and not restock on the pole? Or did you take the patient down for a radiology procedure or a procedure somewhere else in the hospital and not take any caps with you? And they flushed down there and didn't have caps available there. So think about what that situation was and how can you remedy the situation so that you have caps available wherever you are in the hospital. Maybe you thought that something is better than nothing. And in this case, that might not be true because the next nurse that takes that cap off has good faith that that needleless connector has been disinfected. So if a cap is there, they may not feel the need to scrub. So in this case, it would be better just not to put one back on there than that, or if you don't have a new one, it would probably be better just not to. But maybe you didn't want to get caught. And we've all been there. So thanks for telling the truth. Next
That's
slide.
great.
Awesome.
If the cap is vented, airflow through the cap could potentially allow for evaporation and drying of the disinfectant in the sponge, and pathogens could re-enter the environment. A non-vented cap offers a sealed environment, limiting movement in and out of the cap to provide continuous disinfection. In effect, it provides a closed system. Along with that, you should know if the threads are also being disinfected. There's a fun way to demonstrate the protection a cap can provide for those 7 days. It's easy to demonstrate the ability of a disinfection cap to protect the connection surfaces. All that is required is a dark solution. Coffee or soy sauce work very well. Apply the cap to the needleless connector or luer connection that will need protection. Then dip for 10 seconds into the dark solution. Remove the cap. Inspect for evidence of ingress on the inner surfaces of the cap, the connection surface, and threads on the luer connection device. That is one way to study individual caps. There are many studies to show great outcomes after effective implementation of disinfection caps. Here are a few studies that have shown good outcomes with the implementation of disinfection caps. Shown on this slide are 3 case studies with great outcomes through the use of human factors engineering. A combined cap with a flush syringe that increased compliance, which led to significant reduction in CABZ and ultimately a financial win for the facility. A systematic review and meta-analysis published in the American Journal of Infection Control in 2019 concluded alcohol-impregnated caps and alcohol CHG wipes were associated with significantly less CABZ than 70% alcohol wipes alone. A pilot random control trial published in the same journal in 2021 also supports the use of caps for the reduction of CABZ. Evidence like these studies support the position of governing bodies. Implementation of disinfection caps is well supported by these governing bodies. INS provides guidance for active disinfection of the connector and outlines the option for passive disinfection. SHEA, in the 2014 update, suggests the use of a port protector for connectors. Those are available for your reference. INS also addresses ways to support implementation and adherence to strategies for best practice. INS and SHEA are not the only ones with recommendations to reduce CABZ. ECRI designated peripheral vascular access harm as number 9 on the list of top patient safety issues for 2021. The studies used by ECRI to support this designation found up to 69% of PIV catheters are removed due to failure or infection before completion of scheduled intravenous therapy. They looked at 27,320 peripheral IV events and found 6,119 reported infections. That's 22% of the catheters removed were due to infection. ECRI has provided us with action recommendations, and among those recommendations are education and assessment regarding proper intravenous catheter use, audit process measures, and to consider the use of sterile techniques and sterile components. ECRI also states that reporting peripheral IV events to a patient safety organization is essential. Guidance and criteria for reporting bloodstream infections are provided through the Centers for Disease Control's National Healthcare Safety Network. When a patient has an infection, if a central line is in place, as well as another vascular access device, it must be proven using their criteria the infection has a primary source other than the central line. The criteria must be met within a specific window of time. Failing to meet their criteria, even when suspicion is strong another source caused the infection, will assign a CLABSI to the hospital. This is the criteria required to prove the primary source of infection is not the central line as related to other catheters. As vascular access specialists, we should work with infection prevention, be aware of positive blood cultures, and assist with identifying other sources. Know, too, that this criteria can change each year. Therefore, it is important to partner with the infection preventionist to understand how these changes can impact the patient and the hospital. PIVs as a source of bloodstream infection really have been overlooked, but they're not the only catheters with potential to cause a CLABSI. Remember, CABSI is catheter-associated bloodstream infection. All catheters have potential for becoming infected. All catheters should be protected because they all dwell in the same pool. Funny thing, the human body does not have separate circulatory systems for peripheral and central veins. It all flows into the same heart. Often, patients requiring a central line also have arterial lines and peripheral lines. For example, consider a neurology patient on a continuous infusion with orders for CT. This patient may need a power injectable peripheral line in addition to the central line already in place. The central line is cared for meticulously. the PIV becomes the source of a bloodstream infection. How will this impact reporting of eclabsy to NHSN? The bloodstream infection will be labeled eclabsy and must be reported unless surveillance criteria can be met for the PIV. In this case, the PIV catheter site must be cultured and match with documentation of phlebitis with pus to rule out primary eclabsy. Why protect half the patient? If the patient has a central line, why not place a cap on PIVs and all the other lines? If an infection occurs, it will be attributed to the central line unless you can prove otherwise. This INS standard states to use a multidisciplinary strategy for education and leadership support and provide consistent feedback to staff regarding outcomes. As always, education for the win in reducing CAPSI. ECRI also recommends a multidisciplinary effort involving leadership, those who allocate resources, infection prevention, clinicians who insert and remove IVs, and patients themselves. The line will need to be protected wherever the patient may be. Remember to offer education to radiology and all the other health personnel involved in vascular access. This requires education beyond the nursing units and may require creative approaches. Educational tools can take many forms, from posters and bulletin boards to demonstrations, handouts such as scratch-off cards, and sometimes vendors may have educational materials to offer for their products, like this Kuros Cap game app for the phone, iOS or Android. Check it out, it's a fun way to learn. Free stuff is always fun to find. Next is a poll question. While submitting your answer, feel free to share in chat any resources that may have been helpful in your facility or resources you wish you could find to provide education.
And let's get the hat moving. Love that hat. So I would use these resources for education. You can use the QR codes on product linked to videos with instructions for use, app resources for your phone, including virtual reality, and ask a coworker. You know, how many times have you kind of sought guidance from your colleagues? I think this is awesome. I always love innovative solutions for providing education. It's the shtick.
Right?
I love it.
I
Yeah.
know.
Share those results. So about 50% of you guys said QR codes. I mean, we use them in the webinar series, so nod to that. But there's a lot of products out there that use QR codes. And yeah, I think they're invaluable, especially when it's like point of service, you know, like using a device or a product and you see a QR code that you can link right to the manual. It's innovative, right?
Yeah, you can even order your meals in a restaurant using a QR code now. If anybody has any ideas they want to offer, just put it in the chat. We'd love to see any thoughts that you might have. If a vendor offered a more in-depth course on a platform like Zoom or Teams or something like that, is that something that would be of interest to you? And how much interest would you have in that? Would you want that to be a unit by unit thing? Like we could just do a special education for your unit, or would you want that to be a hospital-wide thing? You know, those types of resources. TikTok style burst education that just highlights the essential elements of a procedure or a process. Is that something that you would like to see or something that you would want? And is that something that you would want your hospital to do, or is that something a vendor that maybe could do for you? PicTok. Oh, how cute. PicTok. That's adorable.
Yeah, no, It's interesting. I mean, you got to reach the audience, right? You know?
Yeah, exactly. And we find that these younger nurses are very tech savvy, much more so than my generation, although we try to keep up. But they're very tech savvy and they learn in a different way. So we have to adjust our education to accommodate their learning style so that, that we can help them to learn and provide good care too. So I love TikTok. That's adorable. Yeah. Thank you. So I guess we can move on to the next slide unless anybody's putting quickly typing in the chat any ideas that they might have.
Yeah, we'll circle back at the end for that.
From my friend Caroline. Yes, that would be Caroline Polly, the fabulous nurse Caroline came up with TikTok. So let's make sure that she gets to have that notoriety from here going forward. All
Awesome.
right. Awesome. Well, thank you. I guess next slide. Audits reveal opportunity for improvement and growth. They're not a bad thing. Look for ways to come together as a team to have great outcomes. Audits can be performed internally by staff on the unit, infection control, or CLABSI teams. Audits can be used for clinical ladder projects. This is a great task for CNAs who want to be involved in quality of care initiatives. Audits may be performed externally by vendors or consulting companies with an objective view from outside the facility. Audits can be done as a snapshot with a percentage of lines observed or a complete audit of every line in the hospital included. Nurse interviews should be a part of the audit to obtain their understanding of policy and correct usage of products. Nurse interviews may reveal lack of knowledge or unwillingness to perform as instructed, and the results can direct next steps. Audits tell where to focus education and encourage compliance, and may reveal the need for a review of policy or a review of product. Nurse interviews during an audit can reveal some surprising results. For example, the nurse I spoke of earlier understood to use disinfection caps, the same cap, for 7 days. She was so confident she led me into the medication room to show me the instructions on the side of the box. Sure enough, it did say the disinfection cap was good for 7 days. The essential element of "unless it is removed" was missing. We were able to have a conversation and correct this misunderstanding. In another case, the nurse educator in a hospital believed friction was needed for disinfection to work. She taught staff to twist the cap back and forth like juicing an orange. These are instances illustrating lack of knowledge, easily fixed by providing the correct information. If the issue is unwillingness to perform as instructed, then another approach will be needed. But one thing is sure, products cannot fix poor practices. Watch the video and see if you can identify infection risk factors.
Time for another poll. Now, I saw a couple really good ones on there. You know, you setting the alcohol swab down. What else, Jill?
Reusing the alcohol, the same one, allowing the clean part to touch the bed, laying things on the bed. You know, you'll see them go in and change their needleless connectors and put, if it's 3 of them, they'll put 3 needleless connectors on the bed. And then, of course, you saw the contamination that was showed up on the hubs.
Scary, right?
Yeah. Uh, There was a question from the previous poll that I really want to bring back up and talk about. And the question and answer. We'll see
Excellent.
where we get to on this one.
Awesome. Well, let's share the results here. So, have you had an in-service on disinfection caps? And 2/3 of our audience said yes.
Good. You know, I'm shocked. I would not have guessed that many had actually had an in-service on caps. It's been a while since I've been on the floor, I'll admit that. But I remember when disinfection caps showed up, they just said, here, put these on your ports. And I think that is a fairly common experience even today. They just kind of show up. And then no one really explains to the nurses why this extra task is going to be important to their patients or important to the care that they provide. Then you have clinicians that are not committed to putting them on and doing the right thing because they really don't have the why that is needed. Things change. For instance, when COVID came along, we were reusing our N95 masks. So we had some unclear guidance on how to use those. When things change, we need to be able to provide that information to our nurses that are on the floor. When things show up on the floor like a disinfection cap does, and they set the box on the counter in the medication room and say, here, put these on all of your ports, then nurses become irritated. Actually, they say things like they'll spend all this money on that, but yet we can't have a Dynamap that we need, or they begin to make value decisions because they didn't have a hand in the purchasing decision. It just showed up. Now there's one more thing they have to do, and then the rules change. So it's very important that we do in service on how to use these products, even though it's so simple. Every needleless connector has different surfaces and different needs. And when I began to read the IFUs, there are actually different instructions and scrub times and all kinds of things on these caps. So we do have to in service on disinfection caps. So we can continue on.
Awesome.
From your policy, a tool to perform an audit can be developed. This slide can serve as a template for creating an audit tool. It doesn't take long to complete a cap audit in a moderately sized facility. It can be completed using a tool such as an app or entered directly into the computer with a spreadsheet. Look at each patient to be observed. Start at the pump and follow to the patient, looking for any port that is not connected and not protected. Depending on the data you collect, it might be helpful to record the type of line the patient has indwelling, and it might be helpful to know where any unprotected port is in the system, meaning, is it a Y site on the infusion tubing, a port on the pump cassette, or a catheter lumen? There may be a pattern to unprotected ports that you'll want to review and address. Staff interviews are helpful to discover their understanding of policy and how to use the disinfection caps. It also might be helpful to observe flush procedures to make certain caps are handled in a manner to avoid contamination. When it's all done, be sure to share the results with your staff. Make sure the audit results are shared in a manner that will provide consistent feedback to staff. Comparing results and outcomes from previous audits will encourage them to keep improving. Colorful visuals like this pie chart of types of lines and the graph comparing this year to last year can be impactful. ECRI action recommendations state that sustained progress will require continued effort. Make sure the feedback includes encouragement. Nurses love swag, and so do CT techs, ultrasound techs, and all the other associated professionals involved in vascular access. Who doesn't like a little random recognition? Make it a habit to carry small prizes for on-the-spot rewards for a clinician who has caps on every port. It doesn't have to be big, a wrapped piece of candy, a coupon for the gift shop or cafeteria, something to convey job well done in consistently protecting patient lines. Same for units. A random surprise for having all ports capped goes a long way in boosting morale and promoting compliance. Bulletin boards to display trends and successes are often a good way to encourage great practices, and they need to know where the unit stands. Make sure to include other areas of the hospital where patients may be vulnerable to contamination when lines are accessed. Remember, too, the patient can be their own best advocate. When a line is inserted, the patient should be taught many things about what the line will be used for, the importance of keeping dressings clean, dry, and adherent, when to report pain, all those things great clinicians review. INS Standard 8 states to teach patients in the proper care of vascular access device. And certainly, avoiding infection through the correct use of a disinfection cap is something the patient and family should know about. An important point to explain is the purpose of the cap and how it should be a single-use item. Patients can only advocate for themselves if we inform them, and how disinfection caps should be used must be explained upon line insertion. Ensure that websites, if they're used, available for the patient or for caregiver education, are reputable, usable, and accessible to the learner. It's also important to make certain they can see, read, and if relevant, hear the instructions. Make sure the patient has the right information available from the very beginning.
And we're back.
Last one.
Poll number 5. You just flushed the line and don't have a disinfection cap. You will insert answer here. I think that's awesome. You know, one of the hospitals I just recently had a colleague tell me about how they were doing some rounding on clamping of lines and trying to improve compliance with that process. And they did little Valentine's Day cards for the units. So those colleagues of mine that are listening, that's a shout out to you guys.
I gave them Valentine's cards if their lines were clamped correctly.
Yeah, they had a cute little like rhyme too with it. It was awesome. I wish I had it. I would have loved to read it on camera. So, all right, well, let's take a look.
Okay.
So 87% of people said leave the bedside to get a disinfection cap.
Yeah, that's good. That's good to hear, and a little surprising too. But that's good news. But that means that you had to leave the bedside. So again, why wasn't it there? Why wasn't it available to you in the first place? When a nurse is going through her task, going through her day, taking care of a patient, it's very common to be called away. So you're in the patient's room doing what you need to do, and then your phone rings or something happens and you have to leave. With the very best intentions to come back and take care of that patient and put that cap on, it might not happen because you have other things. You have competing priorities, other things that have to be done. So it's really best if we take advantage of human factors engineering and have a cap for you at the bedside and available. Talking about PPE, if you are in a room and wearing PPE and then you don't have a cap, what are you going to do? Flag somebody down to come and bring you a disinfection cap? Probably that's not going to happen. It might. But again, why don't we have a disinfection cap readily available? If there's one right there on your flush syringe, it's easy to use and hard to forget. So if your final flush has a cap right there on it, you're ready to go. So I'm really glad to see that number of people that would leave the bedside. I'm a little surprised, but happy to see it anyway. So, okay, on to the next one. Speaking of insertion, we can take advantage of human factors engineering to begin best practice upon line insertion. Studies show improved outcomes through the use of human factors engineering. We tend to leave things as we find them. Once the cap is in place, it will remind clinicians to have caps available following subsequent accesses. Apply caps to all ports when a line is inserted. Standardize practice throughout the system, from ED all the way through to home health. Every port in every venue can be a source of infection. Caps should be supplied in a manner that can be applied with ANTT, avoiding practices such as laying the cap on the bed while the line is flushed. A disinfection cap integrated into a flush syringe is handy to use and available without a shopping trip. It's already in your hand. Ease of use and compliance are important when selecting disinfection caps. Implementation of a disinfection cap throughout the healthcare system removes the variables of how long to scrub and how much friction and which disinfectant to use. Bright colors make compliance monitoring easy to further reduce variability. Look for a cap to provide a closed system to touch and airborne contamination, and of course, continuous disinfection, bathing lure threads as well as the top of the connector throughout the 7 days of application. All of these can help in the challenge to eliminate CABZ. Now that we're familiar with insertion bundles and improving on insertion-related CABZ, our focus should shift to maintenance. Disinfection caps have proven to be an effective tool in preventing CABZ in the care and use of vascular access devices. A growing body of evidence and governing bodies support the use of disinfection caps. Education, support, and human factors design can help in promoting compliance in your facility. And these are the references.